Every can of soda you consume delivers a surfeit of fructose and phosphoric acid. Fructose metabolism in the proximal tubule generates uric acid, which induces endothelial dysfunction, intrarenal vasoconstriction, and oxidative stress. Phosphoric acid promotes calcium phosphate crystallization, increasing the risk of nephrolithocesis and interstitial fibroses. Over time, these insults precipitate glomerular hyperfiltration, mesangial expansion, and ultimately, glomerular. In plain terms, habitual soft drinking speeds up the scarring of your kidney's delicate filtering units, leading inexorably toward renal failure. Other major causes of chronic kidney disease, while soda abuse is a potent culprit. Remember that CKD is uncontrolled hypertension exerts relentless pressure on the glomerular capillaries, causing gradual basement membrane thickening and diabetes mellitus, particularly type 2, triggers non-somatic glycation of glomerular structures and activation of the renin-angiotensin-aldosterone system, driving intraglomerular hypertension and progressive nephron loss. Autoimmune diseases can spark immune complex deposition in the glomerular. Chronic use of nephrotoxic drugs such as nonsteroidal anti-inflammatory drugs or certain antibiotics further aggravates tubulointerstitial damage. And persistent obstructive yaropathy. 2. Kidney stones. Benign prostatic hyperplasia or retroperitoneal fibrosis leads to back pressure injury and alarming clinical signs you must not overlook.
Many patients remain asymptomatic until their estimated glomerular filtration rate has plunged below 60 milliliters per minute, 1.73 square meters, by which point significant nephron loss has already occurred. However, pay attention to these red flag symptoms. Persistent proteinuria of foam in your urine that does not dissipate after rinsing indicates significant albumin loss and glomerular barrier disruption. Nocturia and polyuria, frequent nighttime urination and high urine volumes, reflect impaired concentrating ability of the renal medulla, edema, swelling of the ankles, periorbital puffiness, and ascites signaled hypobulimia and sodium retention, unexplained hypertension, a sudden rise in blood pressure, resistant to multiple medications, often accompanies decline in renal function, electrolyte disturbances, refractory hyperkalemia, or phosphate retention portend advanced tubular dysfunction. Arrhythmic symptoms, nausea, anorexia, metallic taste, pruritus, and mental clouding indicate toxin build. If you experienced any combination of these, especially persistent foamy urine or uncontrolled hypertension, you must seek nephrology evaluation immediately. Preventive strategies. Stop the damage before it starts. Eliminate sugar-sweetened beverages. Replace sodas with plain water or herbal teas. Aim for at least an L of fluid per day, unless contraindicated by cardiac or renal tension syndromes. Blood pressure control. Keep your systolic reading below 130 mmHg and diastolic below 80 mmHg. Utilize ACE inhibitors or ARBs as first-line agents. Not only lower pressure, but also reduce glomerular hyperfiltration. Glycemic management. Target an HbA1c of 6.5 to 7.0%. Use metformin SGLT2 inhibitors or GLP-1 receptor agonists, which have proven renal protective effects. Avoid always check drug dosing when renal function is compromised, and inform every healthcare provider of your kidney status. Maintain ideal body weight. Obesity exacerbates hyperfiltration injury. A BMI between 18.5 to 24.9 kilograms per square meter reduces metabolic burden on remaining
Dietary modifications for kidney protection. A renal-preserving diet focuses on modest protein restriction, reduced sodium, and careful phosphorus control. Key principles. Choose high biologic value proteins. Eggs, lean poultry, and fish impose less nitrogenous waste per gram of protein. Limit processed foods. These are loaded with hidden phosphates and sodium additives. Increase antioxidant intake. Berries, bell peppers, and leafy greens combat oxidative stress in renal tissue. Monitor potassium. If your serum potassium exceeds 5.0 MEqL, restrict hypotassium, fruits and vegetables, or use potassium-binding agents as prescribed. Ensure adequate calcium to offset phosphate binders and maintain bone health. Aim for 800 to 1,000 milligrams of dietary calcium, preferably from low oxalate sources. If you have established renal impairment, once eGFR falls below 60 ml per minute set to coma tujatiga meter per segi, or proteinuria persists above 300 milligrams. Day early referral to an they may recommend pharmacotherapy, intensify, ROS blockade, or initiate bicarbonate therapy for metabolic acidosis. Anemia management. Administer erythropoiesis-stimulating agents to correct hemoglobin levels, improving energy and reducing left ventricular strain. Bone mineral control. Utilize phosphate binders and vitamin D analogs to prevent hyper. Hey there, welcome to our channel. I'm a board-certified nephrologist, a specialist in kidney diseases. And today I'll be talking about what is called renal replacement planning. One of the questions that patients ask me all the time is, when should they start dialysis? When will it be too late to start dialysis? So I'm going to talk about this topic and hopefully answer some of those questions. So if your kidney function has dropped to an eGFR less than 20 milliliters per minute, then it's time to have a discussion about renal replacement therapy or renal replacement planning. It doesn't mean that you need to start dialysis tomorrow, but it does mean that it's time to talk about what are your goals, what are your options moving forward. Is it hemodialysis, peritoneal dialysis, or preemptive transplantation? And this is really important because we want to get ahead of things before things become urgent, and also because sometimes waiting until things are urgent can result in missed opportunities. We can still have these discussions if you have an eGFR greater than 20, but it becomes more pressing and more urgent as your kidney function continues to decline. At an eGFR of less than 20 milliliters per minute, most people do require some form of renal replacement therapy. You might not be ready for dialysis yet, but you definitely need to be thinking about and discussing your options with your things that can help us make that determination include how well you're feeling, how much fluid you're retaining, whether you're having trouble sleeping or concentrating, and how well you're able to eat and drink without being sick. This is a great time to explore your goals and values as well as your worries and fears so you can make the best choice for yourself. If you feel pretty good, then maybe you want to hold off on dialysis a little longer and try to see if you can get on the transplant list and get a kidney transplant. Transplant is always the first choice for patients who have an EG, but to be on the transplant list, you usually have to be on dialysis first. If your doctor thinks you're not quite ready for dialysis yet, then you may be offered peritoneal dialysis as a way to buy some time before starting Peritoneal dialysis is usually reserved for patients who aren't well enough for or it can be used as a bridge to transplant. Peritoneal dialysis also allows you to dialyze at home, which gives you a lot more flexibility with your schedule. Some people choose peritoneal dialysis as their long-term solution, but it does require commitment to doing exchanges regularly, and there are risks of infection and other complications. If you choose peritoneal dialysis, we will teach you how to do it yourself, and you'll need to do it every day. Hemodialysis is usually done in a dialysis center 3 times a week, 4 hours each time. Some centers offer overnight dialysis, which can be a good option for many people. Hemodialysis is effective at removing waste products from your blood and extra fluid from your body. It also allows you to get on the kidney transplant list. There are risks with both peritoneal dialysis and and we'll talk about those with you so you can decide what's best for you. I know many of you don't like to think about what could happen in the future, but thinking about these things now can help you stay in control. It also helps your doctor develop a plan with you, not for you. Plans change as your health changes, but having these discussions early will help you and your doctor be ready when the time comes. Chronic kidney disease is often a silent assassin, creeping forward until irreversible damage demands a lifelong dialysis or transplantation. Each soda you sip, each unmonitored over-the-counter pill, and each missed blood pressure check inches you closer to kidney failure. The ominous crackle of a fire tower in the dead of night, or the unseen footsteps around your van, remind us the most perilous threats often lurk where we least expect them. Likewise, your kidneys, hidden, silent, suffer harm long before you hear their cry. Act now, abandon sugary drinks, master your blood pressure and glucose, and embrace a renal protective lifestyle. Your kidneys have carried you thus far. Repay them with vigilance and care, lest you awaken one day to a verdict of irreversible kidney failure. Thanks for watching. Remember to like and share for more valuable health insights. Stay healthy, stay informed,